More than 10 million people in this country have asthma. Between 1979 and 1987, the prevalence of asthma in the U.S. rose approximately 1/3, increasing from 3% to affect 4% of the population. In that same period, hospitalizations for asthma have jumped significantly in children. For nearly a decade, age-adjusted mortality in blacks has been rising at over 6% per year. And the price tag for asthma care in this nation has topped $4 billion annually. Hello, I'm Dr. Bill Crounse. In response to these alarming facts about asthma, the National Heart, Lung, and Blood Institute organized the National Asthma Education Program, an initiative that combines the efforts of major scientific, professional, governmental, and voluntary organizations. The program's expert panel was charged with updating our knowledge of the illness and establishing guidelines for asthma prevention and management. The report of the expert panel, which identifies dangerous public and professional misconceptions about the illness, has now been released, and in this program, we'll bring you the highlights of that report. In a previously recorded interview, we spoke with one clinician who is thoroughly familiar with the report. He is Dr. Albert Sheffer, chairman of the expert panel and clinical professor of medicine at Harvard Medical School. And Dr. Sheffer, what are the key objectives of the report?
Asthma has been recognized since biblical times. We now have evidence that asthma is due to an inflammatory process. This report capitalizes on that observation by suggesting that anti-inflammatory agents are used early in the course of therapy and that all asthma sufferers should have an objective parameter of assessment in evaluating their response to this therapy. The objective of the report, Guidelines for the Management and Diagnosis of Asthma, was to help identify the serious asthma patient, provide adequate care for that patient, and hopefully reduce asthma mortality. The objectives for the program itself, really, there are 4 goals. We want to develop a medication program for most asthma sufferers, and we developed this into patients who had mild, moderate, or severe asthma. There's a section related to patient education. We wish to have the patient develop a partnership with their physician. Also, is there a section devoted to environmental precautions and how to deal with environmental factors relating to asthma. And the 4th area, of course, is the objective parameter of assessment, evaluation of asthma by peak flow meter assessment.
What are some of the newer, more important points regarding asthma pathophysiology and treatment?
Central to the appreciation of asthma is the recognition now that inflammation plays an important, if not primary, role in perpetuating asthma. That means that when an asthma sufferer is exposed to an allergen, there's an immediate constriction of the airways, which is relieved without therapy over several minutes to hours, and then about 4 to 6 hours, a more sustained constriction occurs due to an inflammatory response. The other important aspect relates to the medications used in asthma. We feel strongly that patients with asthma should be treated with anti-inflammatory agents early in the course of therapy. Anybody who is receiving daily therapy in the form of a theophylline drug or a beta-2 agonist, bronchodilators, should also have an anti-inflammatory drug administered as well, such as cromolyn or a topical steroid.
Dr. Sheffer, thank you. We'll ask you to expand on other points in the report later in the program. Now, also from a previously recorded interview, we turn to another expert. Dr. Michael Callender is a leading asthma researcher and is head of the allergic disease section of the National Institute of Allergy and Infectious Diseases. How would you outline the key steps in asthma management?
The key steps in asthma management are to identify the causes for an individual's asthma. then to work out an educational program so that the patient understands what is going on in his body and the best ways that medicines are used to reduce those problems, and then to work out a specific treatment plan for the individual patient.
Dr. Callender, you distinguish between specific and symptomatic treatment. Could you explain?
The concept has been that there are two classes of agents used in the treatment of asthma. There's symptomatic drugs and specific drugs. The symptomatic approach is using bronchodilators that reduce the symptoms of the disease. And the specific approaches reduce the underlying disease that causes asthma. So it reduces the need for symptomatic treatment. Specific treatments include allergen avoidance, in some patients allergy immunotherapy, cromolyn, and inhaled corticosteroids. And every patient we see goes on one or more types of specific therapy, and they also use symptomatic therapy as they need it.
Reversing the upward trends in asthma morbidity and mortality must begin with timely diagnosis. But as physicians, we know that asthma can present in varying and sometimes subtle ways, and that patients may tend to deny their symptoms. What's more, our profession has been handicapped by misconceptions and lack of information. These are problems at which the National Asthma Education Program Expert Panel report is directed. Aware of both the problems and solutions proposed in the report is Dr. Gregory Owens, Associate Chief of the Division of Pulmonary Medicine at the University of Pittsburgh.
10 years ago, there was no recognition whatsoever that airway inflammation had any relevance in asthma. We talked about reversible airways disease or bronchospasm. And now we realize that airways inflammation really underlies the genesis, the pathogenesis of asthma, and is very tightly linked to the airway reactivity that asthmatics suffer from. If a patient has mild episodic symptoms, you would treat those symptoms episodically with a drug like a beta agonist. If the patient needs more medications than that, the next step is the use of inhaled corticosteroids. And now we're treating both bronchospasm and airway inflammation. Once we get to that point, you have to then look very carefully at the patient to see what the next step really is, since there are 3 or 4 other classes of medications that have to be thought of then. Medications that need to be thought of at that point are theophylline, which is particularly effective in patients with nighttime asthma. There are cromolyn sodium, which is particularly effective in patients who have allergic asthma. And there's ipratropium bromide, which is particularly effective in patients who have more severe asthma and are older. Then the final step after that is the use of oral corticosteroids. I believe that primary care physicians can certainly use the first two sets, the beta agonist and the inhaled corticosteroid, certainly before the institution of oral corticosteroids. A referral should be made to a specialist.
Our thanks to Dr. Owens. Dr. Sheffer, what is the benefit of a spacer device such as Dr. Owens was demonstrating?
The benefit of using a spacer device is mainly related to the irritability of the airway. If the patient notices irritation of the airway when they use any metered dose inhaler, be it topical steroid or beta agonist or cromolyn, they should use a spacer. And a spacer is also helpful in those individuals who can't be trained to inhale properly at the time the metered dose inhaler is being used.
Dr. Sheffer, summarize the take-home messages of the National Asthma Education Program Expert Panel report.
This report emphasizes that the care of the asthma sufferer is a partnership between the patient and the patient's physician. Secondly, that they both understand that asthma is an inflammatory disease. Thirdly, that there are drugs that combat that inflammation, cromolyn and topical steroids, and those drugs should be used whenever patients are receiving daily therapy. Next, anybody who has asthma should monitor their asthma for any deterioration in their pulmonary function by the peak flow meter.
Many thanks, Dr. Sheffer, and thanks also to the other physicians and their patients who've contributed to this program.